introduce Dr. James Murphy, who is a senior lecturer and otolaryngology consultant at the Tamale Teaching Hospital in Ghana. And he'll be presenting on the otologic dysfunction in patients with COVID-19 systemic review. We look forward to that. Thanks, Dr. Murphy. A few house rules. Please keep your microphones muted for the duration of the meeting, please. If you have any questions, please post them on the chat function. And also, please register with your name, credentials, country, and institution in the chat function. Dr. Murphy, I'll allow the share screen, and we look forward to your lecture. Dr. Murphy, I think you are still muted.
Good morning, everybody. Thanks for giving me the privilege of making a presentation. Just to give you a little background before we start, this is our hospital, Tamale Teaching Hospital. It's in northern Ghana, which is the rural section of Ghana, the poorer section. We have three otolaryngologists there, Dr. Jesu, Dr. Dama, and Dr. Apoku, also myself. And I've been there about 13 years. Currently, I'm in the United States. This is the United States. I left because of the pandemic. My wife, Cindy, and my daughter panicked and got me the last flight out of Ghana before the airport was closed for several months. And so prior to going full-time at Tamale Teaching Hospital for the last 13 years, I was in private practice in the United States. And I had the good fortune of training under a couple prominent United States physician, Dr. Shambo, who edited and wrote The Surgery of the Ear, and then Dr. Mike Glasscock. And then I did some head and neck fellowship in Pittsburgh with Dr. Arena. So I'm not an expert on, I'm a clinician, and I'm not an expert on the viruses that I'm going to talk about, and I'm far from an expert on Zoom. So that's my biggest concern, that I'm going to get lost in Zoom presentation. So the terminology SARS-CoV-2 is for the virus, and COVID-19 is the disease, but forgive me, I'm going to use them interchangeably. So right now, two of my sons, I have three and a daughter, have their families have gotten COVID too. And one of my sons has just had it this last week, and he still has a cough, congestion, and runny nose, a headache. My wife and I, my other son and daughter, have not had it, and my wife and I are scheduled for our second immunization on March 3rd. There's my email. So what I'm basically talking about are viruses that cause ear disease. But what prompted this is this excellent article, SARS-CoV-2, that came out of the University of Witwatersrand, that you're probably all familiar with. So this is the 5 topics that I'm going to speak about. And the first is the review of this excellent article, and I congratulate the doctors from the university, an excellent article. I'm going to talk about how our pandemic has caused our immunizations program throughout the continent and throughout the world to go on hold. And this is making a big difference on some of the viruses that were under control, like measles and chickenpox. We're going to be seeing a lot more of these, and we have to think about that. And then since we're talking about viruses that cause hearing loss, we'll review some other viruses that are not part of the immunization program, but who we'll see clinically. The pandemic, the fourth topic I'm talking about is how it's wreaked havoc with communication, especially with the hard of hearing. And the final topic will be some guidelines for Africa and for ENT in general. So there are the 5 general topics, and take about 40 minutes. The first 3 are a little more extensive. The last 2 are very short. So this is the article that hopefully you're familiar with, and you read, and I recommend it highly. Basically, what they did a search of the world literature, and they found 28 patients that had COVID-19 or SARS-CoV-2 and with different hearing problems, vertigo, hearing loss, tinnitus. There were 8 articles out of 7 countries. And all these patients had hearing tests, either standard audiometry, air and bone, or otoacoustic emissions. And they all were positive with the polymerase chain reaction for SARS-CoV-2. So these are the cases that they discussed, and these are your colleagues that you should all compliment them highly on a nice article. The patients presented either before, patients could present a week before they came down with COVID, during or after they came out of a coma. So before, during, or afterwards. Now, this is really, they found that all these patients were positive on polymerase chain reaction, but in a way that's not good enough. This virus, the SARS-CoV-2, is part of the corona family of viruses, which is the same as SARS, sudden acute respiratory syndrome, and the same as MERS, Middle East respiratory syndrome. And these viruses have been studied for over 10 years. All the scientists know quite a bit about these viruses and other coronaviruses. And they've isolated these viruses from serous otitis media, and they've on postmortem from the temporal bone, temporal lobe, brainstem. And this has to be done with SARS-CoV-2 before we can definitely say it's a proof. But these countries where these articles were written probably did not have the capability. But I'm sure within a very short time that on postmortem specimens of the temporal bone, they'll be doing, they'll get positive polymerase chain reaction, and then it'll be a definite proof. Then it'll follow Koch's postulate that when you have an infection, you isolate the organism you think is causing the infection, you give it to another patient, and they get sick, and you isolate the organism again. Now, this can't be done with this because it's unethical, but at least the polymerase chain reaction on the postmortem temporal bones can be done and will be done, and then it'll be a definite proof that it's a cause of ear dysfunctions. The other thing that we don't know yet, is it a cause of congenital hearing loss? And that, again, will come up and be identified and found out soon enough. Now, the pathophysiology, again, the article, and they said that they postulated the etiology from other studies on coronavirus and SARS and MERS. And it's interesting that on the SARS-CoV-2, on the coat of the virus, there's proteins sticking out the coat, and they call these stick proteins. And they go into receptors on our cells, like a lock and key mechanism. And the receptors on our cells are the ACE inhibitors, the angiotensin converting enzyme inhibitors. That's the lock that it fits into. And this is important because the scientists are working to develop antibodies against these stick proteins. And that's what our immunizations are that we receive. They're messenger RNA that stimulate our cells to produce antibodies against some of these proteins, the stick proteins that are on the SARS-CoV-2. So this virus has a tendency to hit the cells of the nervous system, the respiratory system, heart, GI tract, the temporal bone, organocorti, temporal lobe. Very much so, it hits the neurological system. As you can see, 28% of the people who have the COVID-19 syndrome have neurological problems. Everybody who's symptomatic has a headache, and it's, according to my son, it's uncomfortable. The other mechanism that the virus attaches to our cells or our respiratory tract and our central nervous system, our nerves, and it just causes death of the cell. And it also goes into the red blood cells, and this causes disintegration of the red blood cells. And this may clog up our arterioles, which is especially maybe a problem in the elder people, that they already have atherosclerosis, and so they clog up their end arteries, the ischemic necrosis of their organocorti or their inner ear. Another mechanism that may be the reason that we get a hearing loss is our cells may have the same type of antigen that's also common to the SARS-CoV-2. And so our immune reaction is destroying, it's like an autoimmune disease. It's destroying our own cells as it's destroying the SARS-CoV-2. The inflammatory reaction, as the cells die, they release a lot of cytokines, and this may cause an extensive inflammatory reaction that may cause edema and death. And this is why the steroids, along with the antivirals, are part of the treatment if you get hospitalized with SARS-CoV-2. Now, we got to be, these people are going to come in with all kinds of hearing loss, with dizziness, labyrinthine problems, with tinnitus, with hearing loss. But in Africa, we have to think that all these hearing loss problems may be due to our herbal doctors, our rural doctors, not from the virus itself. And we've all seen so much toxicity from our herbal doctors. Now, the second topic that I'll briefly discuss is the immunization programs against the viruses that have really run havoc in man are all on, many of them are on hold. Just like we're not doing regular surgery, our health departments are not immunizing. And this is a big problem. So here are some of the consequences of the pandemic. As you can see, many children are missing their vaccinations. 158 million people are no longer being vaccinated because of all the restrictions. People not going to work, the public health program stopping down. 41 countries have stopped all immunizations. And other countries that have delayed some of the immunizations, they're having outbreaks of measles. So we're going to definitely see more measles, more mumps. And we'll talk about some of these viruses that we immunize against. So even before in Africa, in Ghana, we didn't get 100%. It's difficult in rural Africa, and also because of the culture, people are afraid of vaccination. So not everybody is vaccinated. And the World Health Organizations and other organizations say that even before the restrictions on the present immunization programs, 13 million infants, and they're mainly in sub-Saharan Africa, did not get immunized, just weren't immunized at all. And at the best of times, Ghana only immunizes 77% of their population. And in areas of Africa where there's strife, where there's war, especially now in Ethiopia and the Afghan region currently, we're only getting 12%. It may even be less today. And the Central Republic of the Congo, Nigeria, Tanzania, in the best of times. And we really should spend money. And it's part of our job to talk to our colleagues in public health and in the government to tell them how important immunization for our field is. Because for every dollar that you spend on immunization, it'll save our countries $58 in medical care. So it's like cost effective. So now this is the diseases that are affected that we're going to see more of because we're not immunizing. And many of them are part of the torch syndrome. Toxoplasmosis is not a virus, but the rest, rubella and cytomegalic virus disease, not cytomegalic torch, cytomegalic virus disease and herpes. So these are some of the diseases that will say, pardon me, I didn't mean to say cytomegalic. We don't immunize against that. There's no vaccine against that. But these four that you see are ones we immunize, and in some countries have been eliminated totally. But now we're going to see more of. So we'll talk about each one briefly. Rubella, or German measles. This just gives a mild infection, a hyperemic flat rash to a mother. But if she's pregnant in their first trimester in pregnancy, and she gets rubella, the 58%, there's a 58% chance of that child being deaf and hard of hearing, or having microencephaly. Some countries like Ethiopia and Kenya do not even routinely immunize against rubella. But I received this information from the internet, so I may not be totally up to date. I couldn't get to the Ministry of Health in all the countries I checked. So currently, from the internet, they're not immunizing. Brazil is not another country that immunizes. It does not immunize against rubella. And of the hearing loss in that country, 30% are due to rubella. So it's some countries are not seeing rubella because they're actively and successfully immunizing all the girls before they in a 12, 11-year-old range, before they have a chance to get pregnant. So they're not seeing congenital rubella. The second disease that's part of the immunization program is measles. And this may be much more important than the SARS-CoV-2 causing havoc and causing hearing loss, because everybody gets measles. It's very infectious. If you have measles and you walk into a room with 10 people who have never had measles, 9 of them are going to come down with measles. And even prior to the epidemic, the pandemic, 500 children a day throughout the world would die from measles. But it's a very good vaccine, but they're not giving it. And some countries no longer have measles in the country. They've had herd immunity and they vaccinated everybody, and they don't have congenital measles or even acquired measles. Now they think measles is why we have otosclerosis. They've done polymerase chain reaction for measles around the stapes foot plate, and the area where the stapes, where the otosclerotic focus is, which is called the fistula antifenestra, the anterior part around the foot plate. And they've been, when they do polymerase chain reaction for that, it's positive for measles. So, but we're going to be seeing more measles, especially in the young children. So this is measles. This is the Koplex spot, which is pathognomonic for measles. This is a measles child. You know, everybody had measles. And when I was a child, I and my siblings, we all had measles and chickenpox. And we all developed hearing losses. And I used to think that it was hereditary, but it probably was due to either measles or varicella, chickenpox. So we can prevent a lot of problems with our good immunizations. Okay, the other disease we're going to see more of is mumps. And this is another disease that in Ghana, we do not, it's not part of the immunization program. You know, many countries that I have listed here immunize with MV, which is measles and varicella or chickenpox. They don't immunize with MMV, which is measles, mumps, and varicella. So in Ghana, I've seen many cases of mumps, and it doesn't cause a hearing loss too much, but occasionally. And not all these children will have hypoplasia of the salivary glands or orchiditis. It's a leading cause of unilateral deafness, and it affects 1 out of 1,000 of the children become deaf. So the final one that I would like to speak about that's part of the immunization programs is varicella and chickenpox. This everybody again would get if they weren't vaccinated. So we're going to see this, and it lays dormant in the body and will flare up. And everybody who was probably over than 40 years of age now has had chickenpox or varicella, because they started immunizing about 40 years ago. And so if you're over 40, you probably had chickenpox, and you probably have the varicella virus in you, along with the cytomegalic virus disease and maybe some other viruses. And this will flare up as zoster or shingles or Ramsay-Hunt syndrome. And that's a painful, painful disease. And 30% of the people who've had chickenpox will get Ramsay-Hunt, will get zoster, shingles. And so there's there's a real good vaccine out that works 95% of stopping shingles from developing. So it's recommended that anybody who's over 50, who's probably had varicella, to receive this immunization and prevent themselves from having shingles or zoster or Ramsay-Hunt, and from losing their hearing, or from having pain, maybe sometime for life, or having a facial nerve paralysis. So this is Ramsay-Hunt syndrome, and the typical, it really goes to nerves, neurotropic, this virus, and it causes a hearing loss. So these patients should be treated to protect them from getting a hearing loss or a permanent facial nerve paralysis with antivirals. This is another case of zoster, where shingles were shown how neurotropic it is, just going along the fifth nerve here and the seventh nerve probably. And so these should be treated with antivirals. Maybe it's the hypoglossal nerve, but I doubt it. Anyway, I'll take your advice. Now, so those four diseases we're going to see more of because of the decrease shutdown of the immunization programs. These other diseases I'm going to talk about now are not part of the immunization program. So that we're not going to see more of these. The incidence of disease are not going to go increase. So this is our third topic out of 5, and the talk will be on the viruses that cause just the congenital hearing loss, and then the viruses that cause both a congenital and acquired hearing loss, and then the viruses that are just causing acquired hearing loss. Now, we already discussed half of them, so there's only about 4 or 5 that we're going to discuss. Okay, so these are the viruses that cause congenital hearing loss. And we already spoke about rubella, so we're not going to, you're going to see more of congenital hearing loss, but we're not going to speak about that. Now, what we're seeing now and we're recognizing is cytomegalic virus disease. Every child, has cytomegalic virus disease, and if you test for it after 3 weeks, it's useless, because every child by 3 weeks of age is positive, has had cytomegalic virus disease, and it's in our systems. And this causes a hearing loss. Most of the children are asymptomatic, but if they're symptomatic, there's a high degree of hearing loss. So the other thing is these children may pass the neonatal screening test, but they'll develop a hearing loss within the first few years of life, and it's progressive. So if you have a child that develops that high hearing loss and it's progressive, you got to treat the child for a cytomegalic virus disease. You got to give them antiviral medication. And this is why we have to test our children in the primary schools. Now, where we're doing cochlear implants, this is the leading etiology of the children with the hearing loss. It's cytomegalic virus disease. Another disease that is a cause of congenital hearing loss is lymphocytic Choreo meningitis virus. Now, this disease you get from rodents, from the feces and urine or saliva of rodents, mice. It's a rare cause of deafness, but if a pregnant woman in her first trimester comes in contact with the saliva and the virus from these rodents, their children may develop congenital hearing loss or defect. Now, the sad part about this virus is that all these children also go blind. And so they need cochlear implants to be in contact with the world. Okay, now the next group are the viruses that cause both acquired hearing loss and a congenital hearing loss. Now, HIV. 30% of our HIV patients have a hearing loss, mainly sensory neural. So look out that and treat them. Their hearing loss may be presented as bilateral sensory neural, maybe unilateral, it may be sudden. They also have, they may have Meniere's disease or tinnitus. And then also the treatment for HIV sometimes causes a hearing loss. So, but the thing is the mother, if the mother has HIV and she's pregnant, if we treat her with heart program, we can prevent hearing loss in the child, congenital hearing loss. The HIV, along with measles, affects the immune system. And so we're more prone to upper respiratory infections, acute otitis media, maybe a flare-up of varicella and cytomegalic, which can cause our hearing loss. Ghana is pretty good with HIV. Our percentage is maybe 2%, maybe a little higher, but it's good. Herpes Simplex, either type 1, labialis, or cervicalis, type 2, is a cause of both acquired and congenital hearing loss. They used to think that the herpes 1 gave you just the lesions around the outer lip, herpes labialis. But they now know that herpes 1 and herpes 2 can give both. It can go to the lips or it can go to the vagina, both of them. And if again the mother's infected during her early trimester of pregnancy, the child will be congenital deafness. So if you see people with herpes labialis and vaginitis, they may go have a hearing loss and they should be treated with anti-herpetic viruses. So this is herpes labialis, and the herpes goes on the lips, the outer lips, where inside the oral cavity, the mucosa, that's a canker sore or a fever blister. It's not herpes, it's just on the outer lips, as far as I understand. Okay, this is the final virus that we're going to speak about, and this causes an acquired hearing loss. We won't talk about, we already spoke about the first three, which are part of the immunization program. But West Nile virus is a virus that they've been studying for 20 years, and it's transmitted by a mosquito. And it's a rare cause of hearing loss. Now, this slide, I hope you can see. I want to spend a little time on it. It's pretty much a repetition of what I said, but it'll point out the severity of the problem. So on the left side, as you can see, we have the different viruses. The ones that are caused congenital hearing loss, the one that called the viruses cause congenital and acquired hearing losses, and the viruses that cause acquired hearing losses. So the congenital, the cytomegalic virus disease here. If the child's symptomatic, if the, with microcephaly or symptoms, 65% of these kids can be hard of hearing, deaf, and it's a severe hard of hearing. There's no prevention for it. If they develop the virus during the first few years of life and you see it's progressive, you can give them antiviral medication. It won't improve their hearing, but it may stop their progression. Rubella. We talked about rubella, how it's the leading cause of congenital defects. And 19% of the mothers who have rubella in the first trimester will have children that can be hard of hearing. We've talked about lymphocytic Choreo meningitis, and 7% of those first trimester mothers, pregnant mothers, will get congenital deafness. And the best treatment for this is to avoid the feces, the saliva, the urine of our rodents, get them out of the house. And there's no recovery to the hearing. Now, the ones that cause congenital hearing loss and acquire hearing loss, AIDS. We talked about AIDS, that 30% of our AIDS patients have significant hearing problems. And then the mothers can be prevented with the heart syndrome from having children, congenital hearing loss. The herpes, again, congenitally, up to 33% of women who develop herpes during the first trimester can have 33% of the children that will develop a significant, profound hearing loss. Now, this is varicella or measles first, which measles causes a profound hearing loss, and it's 3%. Now, that's maybe higher than what SARS-CoV-2 is causing. It's causing symptoms about 2%, 3%, 1% in our adult population. But measles causes a hearing loss and up to 3%. And, it's just 3% of millions and a billion people are a lot of children developing hearing loss. And this may be where myself and two of my siblings developed a moderate hearing loss. And the vaccine is excellent for it, but we're not vaccinating as much. The varicella, chickenpox, this again may be why I have a hearing loss, and it can be up to 85% of people who get it. But the figures are all over. Different articles give you different figures for why we get a mild to moderate hearing loss. But maybe this figure is to prevent. I'm not sure. But the vaccine against the flare-up of acyclovir of zoster and shingles is excellent, 95% effective. The mumps, again, is not a big cause of hearing loss, but it's preventable, but we don't immunize in many African countries against mumps. And the final one, West Nile virus, causes a hearing loss rarely, and the vaccines are in trial. And this is caused by the mosquito. Okay, now another chart that I'd like to spend a little time with. The viruses that we all talked about, it's repetitious, are on the side here, and where they affect, where they cause the hearing loss. The cytomegalic virus disease. They think that maybe it's the immune response, that all the cytokines released, and it causes the hearing loss, like an autoimmune disease. And going down to rubella, measles and AIDS, both of them decrease our immune system. And so we can get acute otitis media, maybe a flare-up of a latent herpes or a latent cytomegalic or a latent varicella disease. And now they've done polymerase chain reaction on post-mortem temporal bones, and they found that positive for like HIV in the organ of Corti, the hair cells, and also with these other diseases, they found them in the cochlear nerve and in the temporal lobe and in the brainstem, and the stria vascularis on these other diseases. And I'm sure with the SARS-CoV-2, on our postmortem exams, we'll detect positive SARS-CoV-2 polymerase chain reaction. And then we'll know for sure, we'll follow Koch's postulate that this is definitely a cause of hearing dysfunction. So this is a guinea pig that the scientists have injected with cytomegalic virus disease. And it shows the toxicity in the spiral ganglion and in the organ of Corti. So this is definite proof of that this is the etiology of this destruction. Now, our fourth out of our 5 topics, and the next 2 are fairly brief, are how this pandemic of SARS-CoV-2 is causing communication difficulties. You can read this, but just wearing mask alone decreases the high frequency 12 decibels. And we should be wearing clear masks, because not only that, we all read lips, and we can't read lips now. Just the social distancing of 6 feet. You know that the intensity of sound decreases inversely by the square of the distance. So 6 feet away, the intensity of the sound of our speech goes down 4 times, or maybe 12 decibels or more. And so between the mask decrease of 12 decibels and the distance decrease of 12 decibels, we're running 25 decibel decrease, everybody. And so, hearing loss, they say in Africa, is 10% of the population. So many of our patients have trouble hearing, and they're not going to hear the advice that you give them. And most of them don't, only 1% of the Africans have hearing aids. Most of the ones who need hearing aids don't have it. And so they'll go home not understanding what you said to the patient. They won't get much out of the visit. So, okay. So how can we communicate better? You should talk to your audiologist. There's many free apps out with the smartphones that you can use to communicate with our patients in the clinic that are keeping social distances, that we all have masks on. One simple procedure is, if they can hear somewhat, just each get a mobile phone. The hard of hearing have their mobile phone turned up to maximum. So if you call them 6 feet away on your mobile phone, they can put their mobile phone to their ear and maybe hear you. If they can't hear, there's an app to do this mini hearing test app. And but some of these apps, you have to look around, talk to the audiologist about the apps. They're free. You have to download them to your smartphone. And but some of them only go for the Android phone, and some go to the iOS or Apple phone. So you just have to download the correct one to your particular phone. I'm sorry, the first one here, this was what I talked about, was just to communicate between 2 mobile phones, the doctor and the patient. But another app that's really nice is you can do an audiogram, a hearing test on your patient. You download this app called Mini Hearing Test. And then the patient, just holds up the phone with the app, and the sound comes out, and they hold their phone down. And when the sound goes away, they take the phone away. It's like an automatic audiometer. When they hear the frequency, they hold the phone down. on their phone, they leave go and they don't hear it. And you'll get an audiogram. Now, it's not as good as an audiologist with their expertise and with masking in a soundproof room, but it's very good. You can do it right in the clinic. It takes, do it on yourself, find out what your own hearing is. Some other apps that, all these apps are free, and you can take a screenshot of this if you wish. I can leave it up for a second. So there's apps that will put your voice out and a text will come out. So the hard of hearing patient, if they can read, will read the text, and it saves you from writing on a piece of paper what you're trying to get across to them, which takes for hours. And these apps give this. Now, they also, like Google Translate and some of the others, that they will translate and put the text out in a different language. And so that's fantastic. Some of these apps, you need a wire from your phone, your mobile phone, to the patient, and you can put on the patient, you can put a headset on, or if it's an Apple device, you can put Apple earbuds. And then some of the advanced hearing aids, it'll go to the hearing aid. Some of it will go to Bluetooth, but some of them you need wire. You know, the old system that's still very effective is what's called pocket talker. You had a microphone and the wire went to like a speaker that the patient heard, held in front of them, and they could hear you better. Now, on my smartphone, I can put it on so it hears voice. I could put it on a conference table at the end of the conference table, and it'll Bluetooth right to my hearing aids. And for me, these virtual meetings, sometimes I can hear better than when I go live. You know, live, I go to a meeting, I look for a speaker and I sit near a speaker. But the virtual meetings, you know, everybody's muted. I hear better, actually. But on rounds, our hospitals are noisy rounds. And so I can take my phone, put it on to pick up voice and extemporaneous sound, and stick it in Dr. Dama's or Dr. Jaso or Dr. Foco's pocket as we make rounds. And as they talk, and I can hear them, it'll Bluetooth right to my hearing aid. So it'll give me less problems on rounds. So I hope you had time to take a screenshot of this if you wish. So this is our final topic, talk about the practice guidelines. Now, what's practice guidelines for the New York City is not practice guidelines for Ghana. We have problems in our operating room. You know, we're lucky to have masks and gowns, and but even so, our sterility could be greatly improved. But in the practice guidelines, we have to think about SARS, COVID-2 coming in with different hearing problems, with Meniere's disease, with tinnitus, with vertigo, with hearing loss, and all the other diseases that are going to be more prominent, especially in the young children with decreased immunization. So again, SARS-CoV-2 may be before, a week before they present with their SARS. So think, be a complete doctor, and consider, if you're suspicious, get a chest x-ray. See if they have characteristic chest x-ray for SARS-CoV-2. Do a pulse oximeter. You know, don't be afraid to get our medical colleagues, send them over to medicine, or hospitalize them and get medicine involved. If they're not too sick and they become quarantined at home, fine, but educate them. So we should only, we should think about testing all our patients before they come to our clinic for the sake of our staff and ourselves. And we should only be doing emergency procedures because in Ghana, we really cannot prevent our staff and ourselves from getting during a mastoidectomy or during endoscopy from getting SARS-CoV-2. So we should just be doing emergency procedures, but we should be doing emergency procedures because the doctors that work in intensive care units who have seen terrible cases with SARS-CoV-2, they're protecting themselves from the SARS-CoV-2. And the dentist, the infectious rate in the dentist is around less than 1%. And so you can protect yourself from this SARS-CoV-2 virus, but you have to be very diligent. But also ear, nose, and throat doctors have died from SARS-CoV-2. So the protective drapes I'll show you about, and even the patient says that they've had SARS-CoV-2 and they're negative for it anymore, they have antibodies, there's still a possibility they may have a mutant strain. So you still have to protect yourself in the clinic. And then we should do effective communication with all our patients. So this is what's recommended when we do ear surgery or we scope people. They say you should get 2 Mayo stands and you put them over the patient, one here, one there. You put the patient underneath there, you did a sterile drape over all of this, and then you cut a hole in this sterile drape, and you bring the drape up and you attach it to the hole of your lens of your drape microscope, and then you're protected too. And then you stick your hands underneath the drapes and you do your mastoidectomy or you do your scoping. Well, in Ghana, we're dreaming that we can do that. Like I say, we're thankful that we have masks and gowns and some drapes. So, in a summary, we're finished with the talk, but just to go over what we spoke about, we talked about this excellent article from your colleagues at the University of Witwatersrand, and you should compliment those 4 doctors, an excellent article. And then we tried to tell you that the immunization programs have been stopped and they've been, should I stop? Anyway, just finish quickly. We're seeing more now of measles, rubella, mumps, varicella, so think of them. We gave a review of the other viruses that are not part of our immunization programs but cause hearing loss. We talked about the free apps that help the hard of hearing, and we talked about the practice guidelines. So I thank you very much. I hope you got something out of this. And these are some of the references that I spoke about, and you can take a screenshot of that. Okay, so I appreciate you giving me the privilege to speak, and I hope it was worthwhile.
Thanks, Dr. Murthy. That was a very extensive and detailed lecture. We really appreciate that, and you've conveyed very useful info on viruses that is causing hearing loss and the mechanisms. I would like to ask our otologist at UCT-Africa Hospital, Dr. Tashneem Harris, if she would like to comment, as I don't see any questions on the chat function.
Thank you, Gerrit. Dr. Murphy, thank you very much. That was a very interesting presentation. And I think it highlights a few things for us. And one of the great concerns is obviously with the focus on COVID at the moment, that we don't forget about all the other preventable infections, that that our focus is still remains on them, that they were issues before, and that with COVID, because of lockdowns and hospitals not being that accessible for patients, that we most certainly will see an increase in a number of the other infections, and this clearly will be a problem. I think one of the, so we just anecdotally have seen patients presenting to our department with hearing loss. Some of the patients who've had COVID infections previously, some of them have clinically have middle ear effusion, some present with sensorineural hearing loss. I have a feeling that there probably are more in terms of numbers, but the problem is that they're not coming to us. You know, there's this fear of coming to hospitals at the moment, and so it'll be interesting to see in the next couple of months as we vaccinate and as things progress and we start opening up services, that it'll be interesting to see the range of pathology that's COVID related that's will be presenting to our ENT department. I have a feeling it's not uncommon. I know I've had someone in the family with COVID, and they also complained of hearing loss. It seemed to be quite mild, and it's now settled. And I think it was a middle ear effusion. But I think that was, you know, that we probably will see a lot more patients coming forward in the future, as services open up. But thank you very much. That was very interesting.
Thank you.
On the chat function, we've just got a comment from Kenneth Baidu in Ghana, who says, in West Africa, another important virus to remember is Lassa virus, which causes a form of viral hemorrhagic fever, and about 25% of survivors end up with a hearing loss. Thanks, Kenneth. And then we've got a comment from Joshua Zoigwe, who asks if Ebola affects hearing, and of that I'm not certain. Dr. Murphy, do you perhaps know if have you read anything about Ebola?
I believe it does, but I don't know too much about it, but I believe it does. And Zika virus also.
Okay, thanks everyone. I don't see any more questions on the chat function, and I don't see any raised hands. Dr. Murphy, thanks very much for this lecture as well, and for all the useful practice guidelines we can take away from here. Just a reminder, we've got case presentations on Friday morning at 8:30. So I would just like to remind everyone about that. The Zoom link will be sent out. And with that, I hope everyone has a good day and good rest of week. Thanks very much.
Okay, thank you.